I'm your host, Chris Hudspeth, and I'm the radio program manager for MS Focus Radio. And I'm joined by Dr. BenThrower, who'll be giving us a COVID-19 and MS update. After the presentation, we'll open it up for your questions and comments. Dr. BenThrower is the medical director of the MS Institute at Shepherd Center in Atlanta, Georgia, where he works exclusively with individuals with multiple sclerosis. Since 1985, the MS Institute at Shepherd has worked with researchers at Harvard Medical School and Emory University to test new MS compounds, investigate new drug therapies, and search for a genetic marker for immune activity in people undergoing various MS therapies. Before joining Shepherd, Dr. Thrower was medical director of the Holy Family MS Institute in Spokane, Washington. He's fully committed to quality care of the MS community. He has worked closely with the National Multiple Sclerosis Society in various capacities and receives the Society's Norman Cohn Hope Chest Award. And Dr. Thrower is also a senior medical advisor for MS Focus. Dr. Thrower was the first physician to be inducted into the NMSS Volunteer Hall of Fame, and he serves as a clinical instructor of neurology at Emory University. We're pleased to have him join us and to present this important topic about COVID-19. Thank you, Dr. Thrower, for being with us, and I'll turn it over to you.
Great. Thank you very much, Chris, and thank you to all of the staff at MS Focus for all of you that you guys do. We really appreciate you. And thank you to everyone who's joining in with us this afternoon. I hope everyone is staying safe in a somewhat challenging 2020 year. We were just joking before we came on. I think on New Year's Eve, we need to throw a case of Corona into a volcano or something to hopefully usher in better luck for 2021. So COVID is a topic that's on everyone's mind in 2020, but probably more so for the MS community. So just wanted to talk a little bit about what we know about multiple sclerosis and the interaction with COVID. We'll talk a little bit about, kind of what we see on the horizon, and then try to leave plenty of time for a Q&A for thoughts and concerns that you folks might have. So we've done a few of these, and some of the things that we have talked about have not, the basic premise haven't changed very much. So when we think about multiple sclerosis, the average person with multiple sclerosis is not at higher risk for contracting COVID and is not at higher risk for having a bad outcome with COVID. Early on into the COVID pandemic, we could really only speculate and theorize about what COVID would look like in the MS community. But now there's a lot of data coming in from a number of different sources. If any of you are interested, you can go on the website. I think we've mentioned this in prior meetings. COVIMS, COVIMS.org is a registry. In theory, it's open to anyone in the world, but 98% of the information that is there relates to people with MS in the United States. And right now, there are 1,300 people with multiple sclerosis that have been entered into that database. If anyone who is listening, if you are a person living with multiple sclerosis and you have had COVID, I would encourage you to put your data in there as well. You can do it yourself. You could do it with the assistance of your healthcare team, but it's pretty straightforward. And what we see in that database is fairly similar to what we see in databases coming from Europe and other countries. And that is that people with MS generally are not behaving differently if they get COVID. So people with MS who are older. And if you look at people who've had a bad outcome with COVID, if they have multiple sclerosis, they tend to be older individuals. They tend to have comorbidities, hypertension, diabetes, COPD, obesity. Those are risk factors for having a rougher time with COVID. One of the things that has changed a little bit with the COVI-MS registry, and I'm not sure why this is, I have a query out to them, is they used to have in the demographics information, they used to break things down by races. So we know in the general public, that the Black community, that the Latino community, and to a certain degree, the Asian community have had a rougher time with COVID. They have had a higher likelihood of getting it, and they've had a higher likelihood of getting sicker with it. And interestingly, early on in the COVID MS registry, we really weren't seeing those racial disparities. It looked like, across white people, Black people, Hispanic people, Asian people, that the outcomes were pretty similar between that. And we could speculate about why that might be. You could argue, well, maybe people with MS, regardless of race, are maybe better, are more likely to be plugged into the medical community. We know that vitamin D, having normal vitamin D levels, does tend to uh, predict a milder course of COVID. And maybe people with MS, regardless of race, are more likely to be getting their vitamin D levels checked and corrected when they're low. But then just they're not doing those demographic breakdowns now, at least as of the past week when I've checked on the COVID MS registry. Um, so the way that I advise people with MS to think about COVID is do the things that you're supposed to do. Think about the risk benefit ratios of your daily activities almost independently from your MS. So, if you're going out, wear a mask. We get some questions on what types of masks. Obviously, there are a lot of different things out there. I think of masks as at different levels. So there are masks that probably are what we'd almost call courtesy masks. You're wearing it in the hopes that everyone around you is wearing a mask and that you're protecting each other. So your cloth masks that maybe someone makes at home, you put a filter into it, and probably even surgical masks to a certain degree. You're wearing that more to protect the people around you. You are getting some protection yourself from large droplets that might be in the air, but you're really doing it in the hopes that everyone that is around you is wearing the mask also, and you're protecting each other. The next level up, I would say, would probably be the KN95 masks. So you have N95 and KN95 masks. N9 is in the 95 stands for the designation that it filters out 95% of particulates. There are higher designations. In theory, you could do a 97 or 99 mask, but it's going to be very difficult to breathe through those because the tighter that filtration is, the harder it is to get air through. So most of the time, people are looking at an N95 filtration. So N95 is the United States designation for that mask. KN95 is the Chinese designation. In theory, they offer the same level of protection. I think that I would still argue that the N95 is the best of the best. If you've ever put on an N95 and then you put on a KN95, you can tell that the N95 is fitted a lot more tightly. In hospital settings, for instance, when we wear N95 masks, we have to have a fit test. So you put your mask on and they put a hood over your head and they put different aromatic oils, to see if you can smell those. If you can smell the oil through the mask, you don't have a tight fit. And so that's the way that we know that you've got a good tight N95 mask. In the clinic here, and I think in a lot of hospital medical settings, I'm using the KN95 mask. I know it's not quite as good as the N95, but it's a lot more comfortable. I don't know if you guys can see this. This is a KN95 mask here. It's off of your face. It's got the two ear straps, whereas the true N95 has the two straps that go behind your head. The N95 is really a hard mask. It's going to dig into your face a little bit. I know for me personally, I can't wear one for more than probably about 30 minutes at a time, whereas these KN95 masks I could wear all day long. If you purchase these, and these are inexpensive, they come in boxes of 10 or 20. Again, that's going to offer you protection and the people around you protection. So this is two-way protection. I would change these out. I would toss it and grab a new one about every 2 weeks, unless it gets wet or somehow damaged, in which case you're going to want to change it more quickly. If you are in a setting where you're really in close proximity to people, there is some discussion about wearing eye protection as well. Here in the clinic, if we are in the exam room, we do wear eye protection. So this could be, I have these, you can get these on Amazon. These are these are actually safety goggles that you could, like if you were doing, construction work or you were at a shooting range, but it also offers you some protection against droplets that might be in the air. Because I'm getting older and I need readers, these actually are readers. You can do them, and they're very inexpensive. They're about $8 or $9 a pair. So you can get those. There's also the whole face shield. So you have your mask and then you wear the face shield over that that's going to protect your eyes. Again, you probably only need those things if you're going to be really in close proximity and maybe you're concerned that you're around people who aren't wearing masks. So you're just offering yourself another level of protection above what the mask is going to offer. Um, the so the other topic that comes up in multiple sclerosis is, what about all of our disease modifying therapies? And so for the most part, our disease modifying therapies have not been associated with a higher risk of picking up COVID. And there are several databases out there. The one exception that we have to mention is that at least in the Italian data set, and this was, I think, reflected in a few other European countries as well, two medications, Ocrevus and Rituxan, were associated with a higher risk of being hospitalized. We have not seen that in our experience. So we take care of about 3,000 individuals with MS. We have had 28 cases of COVID that we are aware of. There could be more, maybe some we've not seen for a little bit for follow-up. And of those 28, 2 were hospitalized. They both recovered. Thank goodness we've had no deaths. Everyone has recovered completely. And within that, the experience of those people, it's been quite variable. Some people have been pretty sick, bedbound for a week or two, really fatigued. And then we've had a handful of people who were completely asymptomatic. Individuals who the only reason they knew they had COVID is they were actually going in for a procedure like a colonoscopy, and the doctor's office wanted a negative COVID test before they came in for their procedure. And lo and behold, the person was positive, and they had it repeated, and it was a legitimate positive. So we've had this pretty wide range from, people who got pretty sick with it to, completely asymptomatic. And I think that that's what the COVID-MS registry nationally has shown as well. In that COVID-MS registry, there is a small chunk of individuals who were asymptomatic. The majority of individuals recovered or are recovering. The death rate in the COVID-MS registry was 4.3% of individuals dying. And again, most of those individuals were people with who were elderly with comorbidities. There has been some question about, could certain MS therapies actually be protective? And I would say we don't know of any for sure that are, but early on into the COVID pandemic, Serono did donate millions of doses of Rebif to researchers. We know that interferons in general, so interferons in the MS world would be Avonex, Plegridy, Betaseron, Extavia, Rebif, that the interferons do have antiviral properties. The name interferon goes, back decades ago to when they were first discovered, and it was found that they interfere with viruses. So it's interesting to think, well, could a person on one of these interferon therapies actually have a lower risk of getting COVID? We don't know that, but clearly they're not putting people at a higher risk for COVID. If a person is thinking about starting a therapy right now, that's obviously a discussion that you're going to want to have with your healthcare team. If a person was thinking about starting Ocrevus or Rituxan, it's not that you can't, and that may end up being the best drug for an individual. But we've always known that monitoring the immune system is vitally important with therapies like Ocrevus and Rituxan, and it's probably that much more important now. Anti-CD20 therapies, Ocrevus and Rituxan, and now we have a third player on the market, Kcentra, the Novartis product. Ofatumumab is also an anti-CD20 monoclonal antibody. What we would like for those drugs to do is specifically work on a subset of B cells in your immune system. And fortunately, we can measure that with blood testing. What we don't want these drugs to do is to lower your total lymphocyte count or affect the T cell population. So nothing in the human immune system exists in isolation. Everybody dances with everybody else. So when you affect one cell subset, like the B cells, it is possible if you push too hard that you could start affecting T cells also. And that's something we want to monitor in people on the anti-CD20 monoclonal antibodies. And so what do we do if we do start seeing those T cell subsets dropping in a patient on Ocrevus, Rituxan, or Kcentra? We're just going to back off on the dose and let those T cells come up. Something that we've been doing in light of the COVID pandemic in individuals on these therapies is also checking antibody levels. And this is not COVID antibody, this is just your general, the total amount of antibody, just as a reassurance that we're not pushing too hard on your immune system. So in patients on Ocrevus, Rituxan, and Kcentra, we're checking your total lymphocyte count. We're breaking those lymphocytes down into B cells and T cells, looking to make sure that these drugs are only working on that one subset of B cells. T cells are normal, and we want your IgG levels to be normal as well. The other topic that I think is going to become probably much more relevant in the next few months would be what happens when we get a COVID vaccine. So there are several vaccines in the running right now. The ones that seem to be at the front of the pack and would be most likely to get approval and be widely used would be the Pfizer product that just got a lot of attention this week. There was a press release showing that preliminary data suggests that the Pfizer vaccine may be 90% effective. AstraZeneca out of the UK, their vaccine is cooking along. There's Moderna, another company. This is going to be an interesting time because once one of these vaccines gets FDA approval, it's not like we can hand someone 3 years worth of safety data and say, this is what this vaccine looks like over long periods of time. There's not going to be years and years of safety data. And I can almost guarantee you that there won't be many or any people with MS in these clinical studies. So are these vaccines, once they're out there, will they be safe for a person with MS? And the simple answer is we just don't know yet. I think we're going to get a lot of help from the National MS Society once a vaccine gets approved in terms of looking at the immunology of that vaccine to give us some guidance as to whether, in theory, we think it would be safe or not. There was a little bit of concern this summer when the AstraZeneca vaccine trial was halted temporarily because one of the study subjects developed transverse myelitis. As most of you know, so transverse myelitis is, it's inflammatory demyelination in the spinal cord. Transverse myelitis is the cousin of multiple sclerosis. So the question is, was this just an unlucky coincidence, or is there some possibility that the vaccine could have provoked this transverse myelitis, and would that mean that it could provoke an MS relapse as well? These are questions that we just have to sort out as we go along. These vaccines, the Pfizer product, the AstraZeneca product, and the Moderna product are different from any vaccine we've ever had. These are all RNA vaccines. So when you think about genetic material, so you have DNA and RNA. RNA is how you ultimately make proteins in the body. And so what they're doing with these vaccines is they're taking messenger RNA, it codes for a protein, from the COVID-19 virus itself. And this is messenger RNA that codes for the spike protein on the COVID. And so the vaccine is that messenger RNA. They're injecting that. That messenger RNA is going to be taken up by human cells. And those human cells in our body are now going to actually start producing the spike protein from COVID. Your immune system then should recognize that spike protein as being something bad and make an immune response to it. In Pfizer's press release, they said that they saw good antibody response, a T cell response, and more importantly, they seem to be actually preventing the development of COVID. The Pfizer product has been studied so far in about 144,000 individuals. Within that 144,000 group, there's a placebo group and a vaccine group, and they're looking at the risk of developing COVID. I think they've had 94 cases of COVID within that study. The way these studies are sort of written up statistically, to say that you really have a true treatment response, they're waiting until they get to 164 cases of COVID before they make a final decision on that. But it is looking very, very promising. So again, interesting technology, somewhat challenging in that we've never had an RNA vaccine before. What we've seen so far in terms of common side effects is a lot of people do seem to get kind of a little achy and feverish after the vaccine. The Pfizer vaccine is actually it's a sequence of 2 shots. And so we'll just, hopefully we'll know a lot more as time goes on. There is a national vaccine allocation committee that is charged with helping ethically determine who gets the vaccinations first. Once a vaccine or vaccines are approved, there probably won't be enough to obviously vaccinate everyone in the world or probably everyone in the United States. And so there has to be some sort of ethical way to say, okay, what are the highest priority needs? Do we do, emergency room workers and respiratory therapists? Do we do nursing home, folks who might be at higher risk? And so that National Vaccine Allocation Committee is going to help make that determination. I think I'm going to take a break there for a second. I think I covered most of what I wanted to cover and throw it out to you guys and see what questions or concerns you might have.
All right, I'm going to come back on video. And we do have some early questions. But before we begin the Q&A, if you have a question or comment, please make sure to use the raise your hand feature in the app or send your question via chat. So to raise your hand, just click on the screen to pull up the menu, select more, it's the icon with the 3 dots, and then click raise your hand. I'll unmute you, and then a button will appear on your screen asking if you want to allow me to unmute you, and just select allow. All right, so we do have a question that came in via email from Jody. She says, vaccines are either live or inactive viruses. Has there been any sort of indication what type of companies are working to provide? That's part one. And then the second part is, as someone with MS, where should I be looking for recommendations as to what vaccines would be safe for me? MS Focus, MS Society, NIH, the World Health Organization.
Yeah, it's a great question. So she's right. Typically, we think of viruses or vaccines as being sort of live attenuated. So it's a live virus that is somehow weakened so that hopefully it can't actually cause the disease, or it's a dead virus completely. So far, the leading candidates for the COVID vaccine are none of the above. They are actually, they're not the viral particle itself. They're the RNA from the virus. So the good part of that is that it's not the virus. So the challenge is, because it's this whole new technology of RNA vaccines, we just don't have years and years of safety data behind that to help guide us. So it will be in all likelihood, a new class of vaccine. There are some companies that are working on vaccines that are just a little piece of the virus. It's actually that M spike protein piece. So it doesn't look like any of them would be a traditional live attenuated or dead virus vaccine. Um, in terms of good vaccine information, I think probably there was a joint effort between the National MS Society and the CDC. If you go on the National MS Society's website and look under vaccinations, they have a whole listing on there of what type of vaccine it is, and then what the general recommendations are for people with MS. So that I think the National MS Society is probably your most concise, easiest place to go for that information.
All right. We have Kay Welsh. Kay, I'm going to unmute you and just click allow me to do that, and then go ahead and ask your question, Kay.
Yeah. Hi. Okay, Dr. Thrower. This is something interesting that came up just real quick. So a couple of years ago, I read about ivermectin as a remyelination drug, and I was following it because it was very interesting. They use it in the mouse models, and it promotes remyelination, and it was an anti-inflammatory. Recently, I had a family member that had COVID and was treated with ivermectin in the hospital. And I thought it was very interesting because it's very cheap. I mean, they use it on dogs too. And I've been following it, like I said, a couple of years ago. And when that popped up, I'm like, oh my goodness, as far as that goes, if you have MS and you're given this drug and it helps reduce the viral load of COVID-19, I just kind of think about in the remyelination. I mean, this is kind of a neat drug. I mean, what do you think about it?
So there's a lot of stuff out there on the remyelination and neural repair front. So that I would say for the past 10 years there has been a huge amount of effort and research put into that. I would say at least a third of the research dollars that are invested through the National MS Society are going towards remyelination and other neural repair strategies. We've had some hits and misses. One of the molecules that we were very interested in for quite a while was anti-lingo. So anti-lingo had kind of a bumpy course early on. There was some of the studies looked good, some didn't look good. But there was just a large study that wrapped up, we were part of, that unfortunately was negative. And so that one I think is probably done. So that other name for that is opacinumab or anti-lingo. I think the ivermectin falls into this camp of there's been a big effort to repurpose molecules. So you take something that's already out there for something and you say, hey, could this possibly remyelinate? One of the models they're using to help identify things that might generate myelin that weren't really meant to generate myelin is this sort of a micropillar array. This was developed through UC San Francisco and the National MS Society. So a micropillar is a little fake nerve fiber or a fake axon in a test tube. You put it, a media in there that cells can grow in. And what you do is you put OPCs, oligodendrocyte precursor cells. So these are cells that will grow up to be oligodendrocytes and make myelin, but something has to turn them on and tell them to do that. So they take a bunch of those test tubes and then they just start throwing the kitchen sink at it. Throw molecules like ivermectin into it and see if that molecule turns on those OPCs and generates myelin in the test tube. The advantage to a lot of these types of studies is it's a molecule that's probably already been through human safety testing. So these are molecules that are already FDA approved for something. You just need to show that it generates myelin. So it cuts through a lot of animal testing. You don't have to do human safety testing. And so there are a lot of these molecules cooking along. There was one about a year and a half ago, and I've not seen any follow-up studies on it, but clemastine clemistine, the active ingredient in Tavist, antihistamine, that in this micropillar array model in the test tube, it generated myelin. So then what they did is took it to 50 individuals with prior optic neuritis. So these were people who had had some degree of permanent visual loss from a prior optic neuritis, and they were at least a year out from that optic neuritis. They treated all 50 in an unblinded fashion with the clemistine, and all 50 had some degree of visual recovery. So those things are really exciting. The other one that is cooking along right now that is different from a myelin generator, this is an axonal generator. It makes new nerve fibers, which in some ways you could say that really gets at the heart of disability in MS, is elezanumab. So elezanumab is finishing up a large phase 2 study right now. It should finish in December, and hopefully we will be moving into phase 3 testing at some point in 2021.
Okay, let's see. We have another question. It's from Kim. She was diagnosed with COVID-19 in July after a previous pneumonia hospitalization that had 2 negative COVID tests. Less than 2 weeks later, on another pneumonia hospitalization, she tested positive for COVID-19. All of the chest x-rays and symptoms screamed COVID-2. Lingering lung damage required 3 more pneumonia hospitalizations, totaling 52 days in the hospital. But since then, she's had 2 antibody tests showing no immunity from COVID, and it's been suggested that the MS medications might be causing that response. Does that sound right?
So the antibody testing for COVID is challenging. The antibodies may not be persistent. So here in the state of Georgia, for instance, if you look at just the percentage of people who have had a positive antibody test to COVID, it's pretty low. It's only about 6% of the antibody tests are coming back positive. That may not mean the person is not immune, though. So again, when you think about human immunity to things like viruses, there's your antibody mediated immunity, which is through your B cells, and then there's the T cell immunity. There is some indication that people may have T cell immunity even when they don't have B cell immunity or antibodies. The practical problem with that is we do not have a commercially available blood test to test for T cell immunity to COVID. There are several groups working on it. There's a big research group out of the UK that is working on a T cell immunity test. It's very important. It's important for a lot of reasons. You know, when we think about vaccines, if the vaccines are not they may be generating more of a T cell immunity than a B cell immunity. So just the fact that you don't have antibodies, you could still be immune through T cell immunity. So could an MS therapy actually be blunting your immune response? Maybe, without getting into your specifics, you could say, well, maybe these anti-CD20 monoclonal antibodies, Ocrevus, Rituxan, Kesimpta, in a small subset of patients, those drugs can lower antibodies. They usually don't wipe it out completely, though. I would think it would be unusual for one of those drugs to completely eliminate your antibody response to COVID. I think if you're antibody negative, it's more likely that you probably had COVID and the antibodies just went away, but you could still be immune from T cell immunity.
All right. So if anyone has a question, please make sure to let us know. And you can raise your hand and use that feature in the app, or you send a question via chat. To raise your hand, just click the screen to pull up the menu, then select more. It's the icon with the 3 dots, and click raise your hand. I'll unmute you, and then a button will appear on your screen asking if you want to allow me to unmute you. Just select allow. We do have another question that came in from the chat from Jessica. Are there any statistics on Zeposia? I think I pronounced that right, since it's so new.
Yeah, so the there really aren't that I'm aware of. Now, I will say that the National MS Society does have a mention of Zeposia, possibly being associated with a higher risk of getting sick with COVID. So Zeposia is in the same class of drugs as Gilenya and Mayzent. So all three of those drugs are what we call S1P receptor modulators. They work on, they keep white blood cells, lymphocytes, locked up in the lymph nodes. They're not killing the white blood cells, they're just not letting them get out and circulate. So when you look at the COVID-MS registry, it doesn't look like patients on those drugs are overly represented in terms of who's getting sick with COVID. So I don't think that there's going to be a higher risk of COVID or having getting sicker with COVID with Gilenya, Mayzent, or Zeposia. I have not seen that.
Okay. Another question from the group chat from Karen. It's not really a question, but I guess she's phrasing it in the like the holiday thought. She has two kids. They're in their 20s and they don't live at home.
So that's going to be the $1 million question, and I think that's it. There is no zero risk option out there, and I think everyone is going to have to make decisions based upon the risks and benefits. There's the risk of getting COVID. We are seeing people suffer from just social isolation and not being around their family. So what I think the way that some people are dealing with that is saying, okay, we're going to still have our family gatherings. We're going to, keep them smaller. We're going to, try to limit, our hugging and kissing a little bit. Maybe the family member gets a COVID test before they come home, just to increase the likelihood that they're not bringing something into the household. There's so many variables in that, and it's, there's not a absolute right or wrong answer. I think everyone's going to have to say what's the risk benefit ratio to me. So I know for us, our family, we're getting together for Thanksgiving, we're getting together for Christmas, but we're keeping the gatherings small. We all know each other, so we know that we're socially distancing and we're wearing masks, so we don't, even though my wife and I are both physicians, we're not in high risk medical practices. So yeah, I wish I could give a concrete answer to that, but I think you could have a family gathering as long as it's small, and you maybe just be smart about it. And if you want to be extra careful, have people coming in from out of town maybe get COVID testing before they come into the household.
All right. Okay, so another question. Oh, again, if you have a question, we have a good bit of time left. Please make sure to raise your hand and or send it via chat, via the group chat. Sarah asks, will you recommend that your patients get a vaccine when it comes out? I presume that will depend on the patient, but in general, if someone was otherwise healthy besides MS, would you recommend it?
Yeah, good question. I'd like to see some thoughts from smart immunologists once we have a vaccine, just to say, okay, how immunogenic do we think this vaccine is? And if they say, listen, we think that this new vaccine is no more immunogenic than, say, the seasonal influenza vaccine, that I would feel pretty comfortable with doing that. If, let's say that a vaccine was associated with more cases of transverse myelitis before it came out, that could be concerning. And we might then ask people to take a little bit more of a wait and see attitude. Maybe we wait until the vaccine's been out for 6 months. I think the other variables that factor into that is, what is the individual's, what is their risk? Are they quarantining already at home? We have a lot of folks with MS who are really, really not getting out and having much exposure. We have people with MS who are doctors and nurses and other healthcare workers or teachers who probably have more exposure. So I think that variable is going to factor in as well as to whether they should be at the front of the line for a vaccine or not. I know, for instance, here at Shepherd Center, we are, like most hospitals, all of our employees, we have mandatory influenza vaccines each year. Our medical director has said, once we have a COVID vaccine, he's not going to mandate that healthcare workers get that right up front. He wants to wait and see. There's a little bit of safety data behind that. Just ethically, it's hard to mandate that someone get a vaccine that's brand spanking new without, at least a little bit of safety data behind it. So yeah, I, I think there are a lot of moving parts to that question, but we'll just have to take it on a case by case basis.
Right. From Linda, if you could, she just wants to know the MS COVID registry again.
MS or COVIMS, COVIMS.org.
Okay, and I believe, Linda, if you look at the very top of the chat, Casey Minnis put that to everyone, so you could find it. Anyone who's looking for that is at the very top of the chat, so you can find it there. All right, we have another question from Kay. For patients on monthly IVIG or low T and B cells post Lemtrada, when should they get Shingrix vaccine, and would IVIG be given as a scheduled if hospitalized with COVID? And does IVIG protect against COVID?
So IVIG is interesting. So as most of you know, IVIG is not FDA approved for multiple sclerosis. There is data out there showing that it can be used in two ways for MS. It can be used as relapse management, maybe for someone who's not responded to steroids, or for long-term treatment if in certain situations, so given on a monthly basis. So IVIG is pooled antibody from a large number of blood donors. And it's in theory, you like to think, well, maybe it could offer you some protection against COVID. It is used in the hospital setting if someone is acutely ill with COVID. It is used to try to treat the infection, along with a lot of other options that are out there. I think theoretically, it's interesting to speculate that it might offer some protection. I don't know that we have any proof of that, though. So you would think that as more and more humans are exposed to COVID, and maybe more and more humans potentially have antibodies to COVID, those antibodies at some point should start showing up in IVIG, because that's what IVIG is. It's pooled antibody from a large number of blood donors. Again, we haven't seen it yet. But in theory, you would think it would happen. So I'm perfectly fine with someone being on IVIG. I think it's a no risk option in terms of raising your risk of COVID. In theory, it could offer you some protection against COVID, but we just don't know that yet. Lemtrada is a whole different animal in terms of what it does affect both B cells and T cells. The B cells come back at about 6 months after a dose of Lemtrada. In the registries, we've not seen any issues with people getting sicker with Lemtrada, but it is potentially immunosuppressant. So I think we want to be at least vigilant in people on Lemtrada. Shingrix, the Shingrix vaccine is a two-part vaccine, so it is safe for everyone with MS. It is not live virus, so I would encourage people to think about getting that. And timing wise, with Lemtrada, I mean, ideally, if you could do Shingrix before you started Lemtrada, that would be best. I would say if you're already on Lemtrada, I probably would try to do it 6 months or more after an infusion, just because then your B cells have repopulated at that point, and you have a better chance of having a good immune response to the Shingrix and getting the full antibody response.
All right. And again, if you have a question, we have a few more minutes. You can send it via the raise your hand feature in the app, or you can send your question via chat. To raise your hand, make sure you click the screen to pull up the menu and select more, and then click raise your hand. I'll unmute you, and then a button will appear on your screen to ask if you will allow me to do that, and please select allow. All right, Karen has another question. She had the flu shot 33 days after Botox was increased in her legs, and now she can hardly walk, and it's 6 weeks later.
So it may be more of a Botox issue than a flu vaccine issue. So, the Botox is used to treat spasticity in multiple sclerosis. It's used for a lot of other health issues, but in MS, it's usually for spasticity management. And there's a fine line with Botox. You're trying to hit the muscles that are giving you trouble with spasms, but you don't want to hit muscles that you're using for function, like walking and transfers. Sometimes Botox works a little better than we want it to, and you could end up with transient weakness after Botox. The good news is that if it is a side effect from that last round of Botox, it's going to resolve itself. Typically, Botox lasts for about 3 months or so. So that if it's really just a Botox thing, that should be transient. Most people with MS tolerate flu shots very well. I don't think there was any interaction between the flu shot and the Botox. If you have a flu shot and you get, kind of achy and a little bit of low-grade fever, you could have some transient weakness, but it should be very transient, 24 hours or less. So if this is going on for more than that, my bet would be it's probably the Botox. We always want to be mindful whenever someone's having new weakness in MS. We don't want to just think that it's the MS or medication. Infections, urinary tract infections. We always say that in people with MS, sometimes the symptom of a UTI is not urological, it's neurological. So anytime there's new weakness and we don't have a great explanation, always think about getting a urinalysis to rule out a urinary tract infection. They can be sneaky.
All right. One more question from Jessica. I'm a teacher and I'm teaching virtually because my neurologist says I'm higher risk. And I'm glad because my school is not allowing guidelines as they should be. Side note. My kids are both learning virtually, even though they have the option for hybrid, their choice because they're afraid to bring it home to me. I let them both hang around outside with 2 or 3 of their friends. It's driving me crazy being home though. So is there a chance of being put on a list for the vaccine based on situations?
That's a good question, and I don't know the answer to that. I think, once we get the vaccine and this national vaccine task force comes out with recommendations, that it's certainly possible that there could be some kind of extenuating circumstance or waiver, request that could go in for that. So yeah, I would say stay tuned. Once we have a vaccine, we should see some federal guidelines come out for, and maybe some waivers that could be, granted. Her question also kind of jogged my memory to mention something that's coming up soon. So if folks are not aware of Can Do MS, so Can Do MS is a group that is very focused on wellness and exercise in MS. Obviously, everything that they're doing right now is virtual as well. They have some great online offerings to try to keep you fit and sane. So their website is CanDo, CANDO -ms.org. In January, they're going to be starting a new program. It's going to be a monthly program that builds on itself, and it's really geared towards helping people with MS cope with the COVID pandemic, coping with the social isolation, towards exercise challenges. So I'd encourage you to go ahead and check that site out. They've got programs ongoing now, but this whole new thing will be starting in January. And I think ideally you jump on board from day one, and so that you can go through the whole program sequentially.
All right, we have a question from Lisa. Lisa, I'm going to unmute you if you would allow me to do that, and then you can go ahead and ask your question.
Okay, so if an MS patient,
We lost her.
All right, let's try this.
If an MS patient gets COVID, are there any therapeutics that you would say, take to your doctor, okay, I have MS, these may work better on me, or look at this first?
Great question. Not really. So there's a whole toolbox of things that can be used in the setting of COVID, from dexamethasone to antivirals or remdesivir. none of those would be contraindicated in a person with MS. So any of those are fair game. IVIG, absolutely fine. So I don't know that the treatment would be necessarily different because of your MS diagnosis, and there's certainly nothing that's off the table for a person with MS. Like any virus, when you get a common cold, there are certain things that the human immune system uses to try to fight off that virus. There's something called gamma interferon that the body uses to try to fight viruses. Gamma interferon is great to help fight off a virus. It's not your friend with MS, so it tends to make MS symptoms act up a little bit. And so, as most of you know, if you get a virus, chances are your fatigue's going to worsen. Maybe you had some numbness or tingling or weakness. Those old symptoms may act up a little bit. We call that a pseudo exacerbation. And COVID, like any virus, could certainly cause a pseudo exacerbation. Those symptoms, those neurological symptoms worsening, that should get better though once your body clears the COVID.
All right. Again, if you have a question, please send it via chat or the raise your hand feature in the app, or if you're online using a computer instead of a mobile device, you will find the raise hand button under the participants menu. So you can look there. And once you do that, if you raise your hand, I'll unmute you. And then a button will appear asking if you want me to do that, and please select allow, or via chat. We always like to get questions that way as well. And we have one more from Mary. What do you think would be the minimum amount of time necessary to judge safety of upcoming COVID-19 vaccines?
Wow, that's a great question. I don't know what the CDC or the FDA, what is their typical time frame. So for FDA approval, I think we're looking at FDA approval coming up fairly soon. And most of these trials have been going, obviously the COVID pandemic didn't start, we're not even a year into it. So we will probably have about a year's worth of safety data. A lot of the side effects that we see with vaccines tend to be right up front. So things like the fever and the aches and pains, those are going to be right up front, usually within hours of having the vaccine, and they usually resolve. Big bad side effects, transverse myelitis, Guillain-Barré syndrome, usually those occur within the first 2 weeks of getting the vaccine. That's probably my biggest concern in the MS community is, are we going to provoke MS attacks? With any luck, we're not. And I think we're going to, if a vaccine is going to do that, it's going to do it probably within the first couple of weeks of the vaccination. Obviously, any of these trials, there's extended monitoring to look for any long-term safety concerns. But I think as it relates specifically to MS, I'm more worried about the acute stuff within the first couple of weeks of the vaccination.
All right, so Dr. Thrower, right now, that's all the questions we have. Do you have any other comments?
No, I think it's just, I really appreciate the MS Focus. I appreciate everyone being online. Stay tuned. Again, we will try to put updated things in the magazine, the MS Focus magazine, on the website. You use all of your resources, the National MS Society, the MSAA, MS Views and News. You take it all in, and just when we get a vaccine, again, probably the National MS Society is going to be the source that will have the first information coming back on safety with those. I hope everyone has a wonderful and safe Thanksgiving coming up. We're looking forward to a normal 2021. And we'll all gather at the volcano and sacrifice the case of Corona to push us in that direction.
It does look like we have one final question.
Sure.
Debbie, you will be the last question. If you would please unmute yourself and go ahead with your question.
Yes, I was curious about
Uh-oh.
We lost her.
Yeah, it looks like we did. Let me unmute you again there, Debbie. Make sure that...
Okay.
There you go.
Any thoughts on using biotin?
So biotin just recently had a negative trial. So there was, there's the normal over-the-counter biotin dose that anybody can use to, stronger hair and nails. And I think that's completely safe and fine. But you're not really using that specifically for MS. And then there was the small study a couple of years ago that in secondary progressive MS that questioned whether higher doses of biotin could actually have a slowing effect or maybe even a reparative effect in secondary progressive MS. The most recent data that came out, though, in a larger study did not find that. So I don't find anything specific to MS that I would recommend biotin for.
All right. Well, thank you so much, Dr. Thrower. I will see you at the volcano with
There you go. Awesome.
And whatever else. Thank you also, Casey, for helping us out today as well. And that is all the time we have. If you missed any part of this conference, it will be replayed on msfocusradio.org and available on demand on our MS Focus SoundCloud page and our YouTube page. Remember to follow MS Focus on Facebook, Twitter, and Instagram for times and access information. Our next teleconference will be Tuesday, November 17th at 7:30 Eastern Standard. Is it Eastern Standard or Eastern Daylight now? I can't. Eastern Standard Time? Okay. With Dr. Maria Houchins, and the topic will be women and MS. Our sincere thanks to all and everyone who attended for your participation, and especially to Dr. Thrower. Thank you so much for your time and you in preparing and sharing the information with us. Thank you so much.
Great. Thank you, everybody. Take care and stay safe.